So thank you very much to the British Junior Cardiologists Association for letting me speak on this subject of cardiovascular imaging, and really what I'd like to do is provide you an introduction to cardiovascular imaging. I'm going to focus on three main modalities of cardiovascular imaging, being echocardiography, CT coronary angiography and cardiac MRI. But chiefly I'm going to focus on echo, and that's going to be the message that's going to run through this webinar, is that when you're starting out in cardiovascular imaging, it's echo that you learn first, and echo is the workhorse of cardiovascular imaging. So it's very difficult to be able to show you how to perform a scan via webinar, but one thing I can do is focus in on the anatomy, which is also particularly important when you're learning echocardiography. And I'll also talk you through what are appropriate indications and what are perhaps less appropriate indications, and that's particularly important for things like cardiac CT, where you're delivering ionizing radiation to the patients. Now, the way I thought I'd show you the different windows and the anatomy in echocardiography was to go through one of my BSc cases. So the British Society of Echocardiography is one way you can become accredited as an echocardiographer in your cardiology training. Okay, so the first view is the deep parasternal long axis view. So here the probe as is just next to the sternum, and the pointer here, the cardiac pointer, which is a groove or sometimes a little button, is pointing up towards the right shoulder here, and you want the depth turned down so you can appreciate some of the extra cardiac structure here. So if you had a pleural effusion, which isn't the case here, you'd see it here, or a pericardial effusion here. So descending aorta, pericardium, left atrium, left ventricle, aorta, right ventricle here, and you can see already, at least to my eyes, that the left atrium looks dilated. And then you zoom in, so you increase the depth here, and so you can get a better look at the heart itself. So exactly the same. So this is the inferior lateral wall, and this is the anterior septal wall here. Try not to get too confused with these initially. So you can already see that the aortic valve comes together nicely, the mitral valve comes together nicely. So it may well be that mitral valve disease isn't the cause of this left atrial dilatation that you can see here. And then really the only thing that you need to do at some point is pause in diastole. So a diastole, bizarrely, is on the QRS phase, which I know is electrical systole, but because there's some delay between the ECG and the heart actually contracting, diastole actually falls on the QRS here. So you stop it in diastole here, and you can get a measure of the left ventricular diameter here in diastole. And if you really want to, you can also measure the walls. And also, the only thing that you really require at this stage is just to have an appreciation of the size of the aortic roots. You don't really need to measure it even, but just when you see lots of normals, you'll begin to get an appreciation of the size of the aortic root. And if you also want to, you can also measure the ventricle in systole, the diameter, and then the echo machine, if it has some degree of auto calculation, will work out the ejection fraction by Tycholz. So a normal left ventricular diameter for a male is up to 6, so it's 4.2 to 5.9, and it's 3.9 to 5.3 in a female, and a normal ejection fraction is greater than 55%, with 45 to 54 mildly impaired, 36 to 44 moderately impaired, and 35 or less severely impaired. But all that's really required at this stage is just to get a measure of the left ventricular diameter. So there should be a button on the echo machine or the ultrasound machine that says colour flow mapping, and you want to look at both valves here. So aortic valve, realistically the colour box should actually cover most of the left ventricle here to see if you can get anything in aortic regurgitation. Essentially what you're looking for is turbulent flow. Now we already know that the aortic valve was opening well, so it's unlikely that there's going to be aortic stenosis here, because visually the valve looked to be opening well. But what you can look for is aortic regurgitation, which you occasionally see. So In this instance, you're looking at when the heart's in diastole. So again, when that marker is on here, you're seeing a jet coming back into the left ventricle. It can be difficult to get your eye in initially, and you just need to see lots before you can get an appreciation of it. And then also look at the mitral valve. So this time you're looking in systole, so just after the T wave here, to see if you can detect a regurgitant jet coming into the left atrium. And there is a very tiny one here, but this is physiological really. Again, it's very difficult to get your eye into this. It just takes a little bit of time to get into it. So then swinging the probe round towards the left shoulder this time. So you want the little pointer on the probe here to look at the left shoulder here, and you'll get the parasternal short axis. And you want to come up and sort of swing the tail up and down until you get to sort of the aortic valve level here, which is sort of the top of the heart here, the first level. And so you can see the RV inflow here, so right atrium, tricuspid valve, RVOT. You can just about see the pulmonary valve here, and then the main pulmonary artery branching into the left and right pulmonary arteries. In most patients, you can also see the left atrium here, but I think because of the atrial hypertrophy, this is quite difficult to appreciate. I think that's the interatrial septum there. It could also be that I've just not quite got the image right. You can also see the three cusps of the aortic valve here, so tricuspid valve, remember, so non-coronary cusp, right coronary cusp, left coronary cusp, and the coronaries come off the left and right. And then all you need to do then is tilt the probe so that the tail of the probe is coming back towards the sternum, and you'll begin to go down through the heart. This is at the basal level, so at the mitral valve. The mitral valve looks like a fish's mouth here, so this is the mitral valve here. And this is where you really want to have a look at the radial function of the heart, so you can get an appreciation of the walls. Again, this takes a bit of time, but essentially anterior septum, anterior, anterior lateral, inferior lateral, inferior, inferior septum. And really what you want to do is stick your finger in the middle there and see if everything's squeezing. Now you can see this doesn't quite look right here, but that's just because I've not quite got it completely on axis, which can be difficult at the base of the heart. But as you come down to the middle level here, this is the papillary muscle level, so the two papillary muscles here. So again, if you put your finger in the middle there, you can see how the heart squeezes on there. And this is just by tilting that tail of the probe back towards the sternum. And then you come back down towards the apex, and what you really like to see is the complete obliteration of the apex here, if at all possible. Sometimes that's not possible in patients. Again, it's just the four walls here because it's much smaller, the apex, septal, anterior, lateral, and inferior. And the next view is the apical forechamber. So this is achieved by sort of essentially putting the probe with the pointers pointing down towards the bed, and the probe really in the apex position, which you use to find the apex beat, although occasionally it can be slightly different to that. And sometimes in very thin patients you can actually feel the apex beat through the probe. So it's essentially cutting through the heart like this, and so you can see the left atrium, left ventricle, right ventricle. And this is looking at the inferior septum and anterior lateral walls here, mitral valve, interatrial septum. And again, you can see those levels that I was talking about in short axis, where you've got the basal, the mid, and the apex there. So it's just looking at, again, in a different view, taking that slice through the heart, so you can get an appreciation of it. Again, to my eye, the left atrium and right atrium look dilated here. And the next thing you'll need to do is take a measure of RV longitudinal functions. This is called a TAPSE, or tricuspid annular planular systolic excursion. Feel free to call it TAPSE. And essentially what it's a measure of is longitudinal function here. So you put the marker here, or the cursor, through the tricuspid valve annulus here, the lateral aspect of it, and you hit M mode, and you get this here as the heart moves up and down with the beat. So the RV has a lot of longitudinal function. That's a really good measure of RV function, is its longitudinal function. So a TAPSE less than 1.6 or 16 millimeters is abnormal. You can see this is very normal. And then you want to put some colour through the mitral valve. So unfortunately I've zoomed in here. You probably don't want to do that. You want to have a zoomed out view where you've got the colour flow blocks all over the mitral valve here. And essentially what you're looking for, again, like you were in the parasternal long axis, is that in systole you get this little regurgitant jet coming back here, and I can tell you this is normal. Although, again, like the others, it does take a while to get your eye in. And exactly the same with the tricuspid valve here, so it's a very small physiological amount of regurgitation here. That's not abnormal. And then by tilting the tail down, you can open up the aortic valve here into what's called an apical 5 chamber. So you get a look at the left ventricular outflow tract and the aortic valve here. Again, you can see the aortic valve opening very nicely there, but this is the measures that you do if you want to put Dopplers through here, but that's certainly not required at this stage. So it's just to get an appreciation of this, and then putting the colour flow through it, you will again be able to see any aortic regurgitation, but of course if the valve's opening nicely, it's unlikely you're going to have an aortic stenosis. And then the final view I want to show you is the subcostal. So this can be difficult to achieve initially. It takes a bit of practice. So probe in the epigastric position here, and essentially left ventricle, left atrium, right ventricle. In this instance, we can also see the aortic valve and the aortic root. So this is a really nice view to look at someone who's in cardiac arrest, because you don't have to interrupt chest compressions. You can just put the probe on here during chest compressions, and that's very useful in the acute setting. And then by turning the probe counterclockwise, you can open up the IVC here. So right atrium, IVC here, this is the liver here, and this looks dilated to me initially. So what you want to do is take a measure of it, and the way to do that is using this M mode here. So again, you line your cursor up, you try and get it perpendicular as you can. You can see I haven't quite managed to do it there, but as perpendicular as you can, and then you essentially put the M mode through here, and you'll get a measure as the patient breathes in and breathes out, and you can get them to sniff to collapse it more, and essentially if it's less than 2.1, you can say that the right atrial pressure is less than 5 millimeters. If it's greater than 2.1, you can say it's greater than 15 millimeters. And it should collapse by 50% when the patient sniffs through their nose. And if it does, then again 5 millimeters. And if it doesn't, then 15 millimeters. And if it only satisfies one of those criteria, you can say it's 10 millimeters. It's a very rough way of being able to estimate right atrial pressure. It's not particularly accurate, but it's just one way of doing it. So in this instance, because it was dilated, and we took another little view here and just moved the probe up and saw this here, and essentially what this is here is a mass in the IVC, and in this patient who originally presented with breathlessness and a raised BNP and anemia, the cause of their symptoms was actually a renal cell carcinoma. So essentially those 17 pictures there that I've shown you is what you need to do on 75 cases over a period of 12 months to become level 1 accredited in echo. So level 2 accredited is what you need for sort of cardiology training, but this is a fantastic thing to do now, and I commend it to you. This was only started in 2018. You only need a cardiology reg who's passed their written exam, or any BSc level 2 physiologist, or really anyone with any echocardiography expertise, who can show to the BSc level 1 committee that they have those expertise. And then you can easily, if you're part of A&E or ED, if you're doing ACCS, or if you're doing IMT and you're on acute medicine, you can easily get this signed off. 75 cases isn't that much. So when you're starting out, I would recommend focusing on ventricular size and function, and obvious valvular disease in the most part, and also get used to looking at the aortic root to look for aortic disease as well. So this is a common role for cardiology SPRs, is to vet the inpatient echo requests to try and sustain the capability better so you don't get lots and lots of requests. It's a very difficult thing to do. I suppose the main one really is patients with a fever and no other suggestive features of endocarditis, which is a very common request for echo, which doesn't yield much, as you can see from the suboptimal pictures that I've shown you so far, which I did. So at any one time, a lot of patients in the hospital have a fever and they can't all have endocarditis, although very grave that the diagnosis is. So you need to have some degree of vetting of echocardiography just to maintain the service, so it can be used for patients who do really need it. Moving on to CT coronary angiography. Now, there's lots of talk between cardiologists about what's the best imaging modality, particularly in coronary artery disease. And the truth is actually that all the imaging modalities complement each other in some ways. However, from my personal perspective, the imaging modality that you really want to use in a patient who you suspect to have coronary artery disease but you don't know is a CT coronary angiogram. So I'm going to start with the appropriate use here of CT coronary angiography. So if you're sat in rapid access chest pain clinic, which you will be in a few years, and you have a patient who presents with typical or atypical angina, or that they've not really got anginal chest pain, but they do have ECG changes, then really the only test that you need is a CT coronary angiogram. And that's in the NICE guidance now, and it's because the clinical utility of this imaging modality is underpinned by its really excellent sensitivity and negative predictive value. So if you don't have coronary artery disease, it can say with a very high likelihood that the cause of your pain is not anginal related. However, it does lack specificity for clinically significant coronary artery disease, and we'll come on to that shortly. For the acute patients, so patients presenting to the acute medical take, which you'll certainly have much more exposure to in your foundation years and core training years, NICE don't recommend using non-invasive imaging routinely for these patients, but that isn't the same for other international guidelines. So the Korean, the European, the Americans do see a role for CT coronary angiography in low risk ACS patients, but that's not in the NICE guidance yet. And really, CT's role there is only to exclude other diagnoses such as pulmonary embolism or aortic dissection. If you want to know more about the global use and comparison of international guidelines, there's a very eruditely written review article here. So what I thought would be useful is to show you the reporting software for CT coronary angiography, because often if you look on PACS, all you get is these sort of stills here. But essentially when you load the CT scan into this reporting software, which you can use to analyse the scans, the software will automatically detect the coronary arteries as long as the CT scan has been performed well. So here is the LAD, and this is the circumflex vessel here, and this is an OM branch of the circumflex, so the AV circumflex goes in the AV groove here. This is a large OM branch of it. So what you can do with the software, you can spin around the artery here, look at the artery from different angles. So this little white blob here is a calcified plaque, and this little grey bit here and there's a little white bit there, is a sort of mixed plaque there. So you can see that they look like they're sort of narrowing the coronary a little bit here. And then what you can also do is sort of zoom up through the coronary vessel as well at specific points. And look here, and it will give you the sort of cross section of the vessel here. You also get a very good anatomical overview here, so you can look at all the other aspects of the coronary and also look at all the other arteries as well. And this is how you should sort of be reporting the lesions. Really what you're hoping to say is whether or not the coronaries are normal, minimal, mild, moderate or severe. But this is merely anatomical information, and anatomical stenosis does correlate quite poorly with functional flow down the coronary. Now in the cath lab, because flow is proportional to pressure, and pressure can be used as a surrogate of flow if you've got maximal hyperemia. So in the absence of any coronary stenosis, the pressure in the aortic root should be the same as the pressure in the vessel distal to the stenosis. And if this ratio of pressure distal to the stenosis and pressure in the aortic root is reduced, then this is a surrogate for ischemia. So that's how in the cath lab you can sort of get a more functional measure of whether or not a stenosis is actually causing ischemia or not. But you can't get this from an anatomical CT scan until now. Some of you may have heard of FFR CT, and so what this does is it applies computational flow dynamics to the CT coronary angiogram data set, and so you can get a calculation of coronary flow and pressure from an anatomical CT scan. So this isn't another scan, this is just using the data set that you've got from the CT coronary angiogram, and then you send this off for analysis and you get the answer back. It used to be overnight, I think you get the answer back in a few hours now. And in February 2017, NICE produced a medical technological guidance on the use of heart flow FFR CT, with approval for use as an option for patients who were offered CT coronary angiography as part of the NICE pathway for stable chest pain. So for those ones who have normal or minimal or mild, you can pretty much say, well, I don't think that stenosis is the cause of their symptoms. But for those moderate to severe categories, you can apply this and it will give you some functional information. It's just another layer of diagnostic acumen. Cardiovascular magnetic resonance, or cardiac MRI. There's two aspects of CMR which I'm going to focus on. So the first is cine imaging, which is steady state free precession imaging, and these are obtained by repeatedly imaging the area of interest for a certain time, typically within a single slice. And for the heart, this is achieved by acquisition at multiple time points throughout the cardiac cycle, and it requires synchronization with the ECG to get this. And you get this short axis cine stack, which is absolutely fantastic for function. So if you want to know whether someone's cardiac function has deteriorated, it's really easy, because you just draw a circle in diastole and then draw it in systole. And there's automated software that does this for you. When I first learned, you used to have to draw all the circles, it used to take forever, but now it'll just do this for you, and you get a really accurate, and you can see how much more accurate this is than calculating it using echo. And so for patients who, for example, are taking cardio-oncology drugs and you want to see whether or not it's affected their heart, this is a fantastic way of doing it. But these images also give you great anatomy here, so you can get a really nice look at all the anatomy. So 4-chamber, 3-chamber, this is actually a sort of RV view, and this is more of an LVOT view here, looking at the left ventricular outflow tract. But you can actually take pictures of the heart however you want with CMR, and that's why it's so fantastic to look at the anatomy. So this is a stack going all the way through the heart here in a patient with congenital heart disease. So they actually have transposition of the great arteries here. So if you sort of go down here, what you can see is that this, which is obviously aorta, goes into the right ventricle here, but the right ventricle is quite thick-walled here, which is a bit peculiar, and the left ventricle is almost thinner than the right ventricle. And the reason why is that this patient has had a mustard procedure, where what they've done is they've switched the flow in the atria. So the caval blood flow now goes into the left ventricle, which then pumps the deoxygenated blood to the lungs. And the right ventricle is then the systemic ventricle, which supplies the rest of the body with blood, which is why it's sort of adapted here and become hypertrophied. This is a fantastic way for looking at how this atrial switch has been performed and how the ventricle is functioning, to measure the function of the ventricles. In just one instance, in a patient with congenital heart disease. Now this operation isn't performed or rarely performed, and they switch the arteries around rather than switch the atria around. And the other use that I want to just draw attention to, as well as that fantastic use of being able to look at the anatomy, is gadolinium. And gadolinium is a paramagnetic contrast agent which alters T1 relaxation times. And you'll remember from medical school the T1 and T2 of MRI. But essentially, MRI images rely upon the signal generated from the behaviour of water protons when you provide a magnetic current to them, and the relaxation of these water protons is affected by the surrounding tissues. And when a paramagnetic contrast agent like gadolinium has been absorbed in its vicinity, the relaxation of the water protons is enhanced. And this is early gadolinium, and it's taking the image shortly after gadolinium infusion, and you get a lot of gadolinium uptake in the blood pool, and so it makes it very easy to see masses. This is a patient who has an anterior infarct here, and you can see that there's a mass here, which is a thrombus at the apex of the heart here. And then if you wait a bit of time, around 20 minutes, and you rescan it, what happens is that gadolinium gets uptaken into the scar tissue, and so this is normal. Here you can see nice black myocardium, nice black myocardium, and here you can see scar here, look, throughout the myocardium due to an infarct. So again, LAD infarct here. So this is functional imaging, and I'm just going to touch on this a little bit. So stress echo here, nuclear myocardial perfusion scan here, and stress MRI here. So going from left to right, stress echo, you tend to give them dobutamine or exercise them, and you're looking for a regional wall motion abnormality. And myocardial perfusion, you have a rest and then you have a stress day, and you're taking pictures with the camera, and you're looking for again impaired perfusion of a particular area. And stress MRI, exactly the same, but using MRIs, and you're looking for that blackness here, which is a perfusion defect there, compared to the other one where you can see that it's all passing through fine. So essentially my personal feeling is that this is best used when you know that the patient has coronary artery disease and you're looking to see how it's progressed, or you're looking to see whether or not it's functionally significant. So for example, if you've done a CT coronary angiogram and you found that the lesion is sort of 50%, or you've even done a proper angiogram and you found the lesion is 50% and you're not sure whether or not that's significant, the patient still has symptoms, you can send them for a functional test, and that will show you whether or not it is significant or not in terms of angina. So this is how, personally, I think these are best used. They all have their drawbacks and their difficulties, and all require a degree of interpretation. Echo in particular also requires you to be able to get some decent images as well, although contrast does help with that a lot. So what have we covered? Well, hopefully I've gone through level 1 accreditation of echocardiography, and I hope I've also given you an introduction to CT coronary angiography and CMR. And if you hadn't heard of it, I've also introduced you to nuclear myocardial perfusion scanning